able to interpret it and therefore be able to use it appropriately is really something that's crossing all our desks, I think. And I hope you will find the presentation coming up will really give us lots of ideas about how that is being done in very exceptional ways, as I understand it, and it will give everyone food for thought. So before I introduce Kevin Hallahan and Tim Anfilogoff from Hertfordshire and West Essex ICB, maybe I should let Jodie introduce them properly as she knows them very well. Jodie, if you wouldn't mind.
Thank you, Paul. I'll just introduce myself. So I'm the Carers Experience Lead in the east of England, and I've had great opportunities to work with Herts and West Essex, especially as they've been progressing their dashboard and data on carers. So without further ado, I'll hand over to Tim and he can do the introductions. Please enjoy.
Cool. Thanks, Jodie. And hi, everyone. So I'm Tim Anfilogoff. I'm Head of Community Resilience with the ICB in Herts and West Essex. I started working on the carers agenda in about 1989 when I was a carers worker in Kent, and I've never really escaped from it since. Also, so I served at the Department of Health back in 2000 on working on the carer strategy then. And I've led the care strategy in Hertfordshire for many years when I worked at the local authority. I'm not a one-trick pony, I'm a two-trick pony, because the other thing that I'm particularly involved with is social prescribing, and was involved with the National Social Prescribing Network from its inception in about 2016. And I'm actually also the carers lead on that network, because it's so important that there's always a risk of looking through lots of different lenses. And that's a good thing, but if the different lenses don't overlap, you can miss out on some really important stuff. So I'm going to say a few things strategically about, I think, the opportunities that we have with both the data that we've got now and are getting better at getting, and what ICSs are for, really. So my first slide, thank you, Steve, that was magical. There are four main aims for an ICS, and what our presentation is all about really is how, and I think it's been mind-numbingly obvious since about 1989 that carers' health was worse than non-carers. But if you're going to get significant change in culture and funding for carers, we need to really make that case strongly. And we'll come on to the fact that we are treating carers as a priority health inequalities group in Herts and West Essex in a little while. But that ticks off the first two, really, because we've got lots of evidence that carers' health is worse than non-carers. We've also got lots of evidence that not looking after carers leads to waste and extra cost to the NHS, and discharges that don't work, etc., etc. And then we also know that carers' economic activity is limited by their need to care, often without the support they need. And all of these things are things that ICSs will want to do something about. Next slide, please. And this is the traditional kind of Health Foundation assessment infographic about well-being and health. And what it tells us is that as little as 10% of what makes us healthy has anything to do with the NHS. The bit that always slightly upsets me about this, and you can say it's true about disability as well, but there are lots of things that aren't on this summary and therefore get forgotten when people are talking about the determinants of health. We have got, since 2021, I can't remember, a document from Public Health England saying that caring is basically a social determinant of health, and therefore when we're talking about the wider determinants, we really must talk about caring, otherwise we're missing out on a huge element of what creates health in our communities. Next slide, please. So in Herts and West Essex for the last year and a bit, we've been working on a health creation strategy with our voluntary community faith social enterprise alliance. And this slide is just to say this isn't duplication. What it's doing is focusing on the unique role of the voluntary sector in helping people to be well and healthy, to know their rights, to get access to support that no one's telling them about, etc. So that's the focus of our health creation strategy, and it sits alongside the integrated care partnership strategy. Next slide, please. That's the picture of our lovely alliance. And you'll see that it represents the committee that leads the alliance represents the 3 different places across Herts and West Essex. Yes, I think that's all you need to know. It's a good spread, but we need to get more diversity in there. Next slide, please. And the strategy as it stands has got 10 key themes. And you see there are some in bold because I think they're particularly relevant to today. So no wrong door. So we've got a lot of work around making sure that people get to the place they need to get to as soon as possible. And that means people working together in a way that makes sense of the complexity of the world. The health inequalities factor is everything that Kevin's going to be talking about. But we know carers find it difficult to access the health service and so on, and get missed and are hidden. And we want people to stay well. And again, if you don't know about the stuff that you can do to do that, that won't help. And obviously, caring itself is one of our strands. Next slide, please. Why does this happen? It looked perfectly good on my version. What have you done to it, Steve? Anyway, I think this is my last slide. But this is about the structures. So I think if we're going to lead on this issue, you need the Integrated Care Board really up on this issue. You need the data in front of them. And the way we've got this working at the moment, our Health Creation Strategy Group, which is the red one, which has gone all funny, both here's from the NHS Carer Strategy Group, which I chair, but also the 2 County Council Carer Strategy Groups, which are all linked together. And we have, for example, task and finishes groups on carers and discharge, which met yesterday, all feeding up into the health creation strategy, which then feeds into another box that's gone funny, the Strategic Health Inequalities Board of the ICS. So that's both local authorities, the NHS, voluntary sector, talking about health inequalities and what we're doing about them. And as I said earlier, Kevin's done brilliant work to make sure that carers are seen as a health inclusion group we need to do particular work on. That group then feeds into the ICP and into the Population Outcomes and Improvement Committee of the Integrated Care Board, where we talk about population health in general. And then this column in the right really is a whole bunch of things that we need to line up if we're really going to do the best for carers. It's a whole system issue, and carers need to go through everything we do, like health inequalities, like the word Brighton in a stick of rock. Otherwise, we're going to be missing out on stuff we could do to make the system run better and for carers to stay healthy longer. Is that my last slide, Steve? It's the trouble with doing them on the day of the event. So that's the kind of strategic context. I think what is absolutely critical is to have some key leaders focused on this stuff, and the data is absolutely fundamental to doing that. But I also would say we had a carer of ours that Jodie knows well, and so do I, present to the House of Lords Committee on Social Care about carers, and particularly pointing out the importance of social prescribing and what he'd seen happening through social prescribing to support carers. And we'll come on to that as well at some point. But yes, you're very welcome to have the slides, and I'll shut up now and hand over to Kevin. He'll give you the nitty gritty. Oh, unless you want to take any questions on the strategic stuff before we get into the detail.
Silence it. Oh.
Will you be sharing your screen, Kevin? I'll stop sharing.
Yeah, I'll share my screen.
Yep.
Steve.
Okay.
Does that work for everybody? Can't see you all now, which is strange. There you go. So my name's Kevin Hallahan. I'm the Health and Equalities Lead for Hearts and West Essex ICB. I have nowhere near as an illustrious CV as Tim, but I've been working in health and equalities for the last year now, actually, in 2 weeks. And it's kind of it's a topic close to my heart insofar as that I'm a nurse by background, and it's just kind of that personalized care everybody needs to have, kind of their needs supported individually. And we need to make sure that we build our structures and systems in a way that everyone can access health care equitably. So this is some of the data. We've been working with a lot of the data around national data and census data to kind of pull together a lot of information just to understand what the impact is on health for those who provide unpaid care in our area. And there is some significant I mean, there's quite a few slides in this deck, and I'll share. I'm happy to share these after, for people to go through in their own depth. There's a lot of kind of some really nice articles there in PubMed, just identifying where we've got all this information from a national context, which I'm sure a lot of you will know. But if I whiz through to where we get through our local data, it's been informed a lot by a lot of the national data, for example, in Carers UK, where we have nearly 1 in 5 have unpaid caring responsibilities. 36% of the community are lesbian, gay, and bisexual carers of a mental health condition, compared with 13% of heterosexual carers. So that should kind of highlight some of the intersectionality of the health and equalities aspects and the lenses that we need to bring to some of this. That you're not just one thing, you're a combination of things, and we need to understand how that interacts in relation to services and your needs, as well as how we respond to those needs. So that moves on to the national GP survey. Again, I'll just fly through these and I'll go into our local data. These will be shared, so I'm sure, and they will be shared, so you can go through them in your own time as well. So just moving quickly into our local data, and to explain the starting point for me when I started identifying and supporting the strategic board to kind of identify, although the EDS 21 had identified carers as an inclusion health group, kind of getting that strategically and recognised through the Strategic Health and Equalities Board, for me, started with a bit of a mapping exercise. We did have a linked data set, and I'll just pause there and say none of this work would have been possible without our BI colleagues and our PHM colleagues. They've been fantastic in providing some of the data and the data platforms that we have. And we're currently waiting, we're in a holding space for a new data platform, which will be all singing and dancing, and we'll do everything that we wanted to do. So that'd be great. And so we're currently waiting for that to come through, to kind of do so, to kind of support this work going further. So I did some understanding from the census, which has a caveat in and of itself, about where our population sat in relation for those who provided unpaid care. And I got to break down by hours, understanding the ethnicity of those who provide care. And then crucially, moving into those who were providing unpaid care, but were also reporting their health not being good. And the next slide goes through that. That combines the last two slides, but it looks at health by ethnicity. And you'll see, for example, those people providing unpaid care who are Irish, although it's a very small population sample in the background, 38% of them were saying that their health was not very good. So there's a need there in terms of the ethnically diverse communities and those providing unpaid care to kind of look at. You can see disproportionate in terms of the amount of people in our area of that ethnicity, but those who are providing care. Moving on then to kind of look at the wider determinants lens, we looked at whether or not, so that's just 12.9% or 0.9% of those who are providing care in our area were economically inactive, and not even those who are in full-time students, which was an interesting statistic in and of itself. There was, but that increased, that economic inactivity increased for those providing more hours of care, which just goes to show some of the, I suppose, yesterday, the parliamentary committee, where they presented some of the information on the carers benefit and the carers allowance in relation to how it needs a bit more review and a bit more work, just makes that case a bit more as well, as far as that it will impact on people's well-being if they're economically inactive, and the cost of living crisis is biting. So it just brings that whole wider determinants lens to the health inequalities as a result of being of providing unpaid care. The next slide then is a bit of a local view of the GP patient survey. It's a little bit busy, so I'll go through it a little bit. It's just highlighting that in the left-hand circle of each of the 4 boxes, you'll see those people who are carers, and in the right-hand column, those who are non-carers. And you'll see the difference is 11% more of those who are carers were reporting long-term conditions of illness. And then, for example, in terms of isolation, 3%, with your 13% versus 10% were reporting social isolation, and less people felt supported if they were a carer. And there is some data that suggests that the mental health conditions are perhaps a bit more stark than what this is purporting, but it's an interesting in and of itself. I'll flick through the next 2 slides because they're very local to us insofar as that this presentation is quite broad in kind of keeping all our data together, but you can have a quite an interesting, an in-depth look when these are shared. And this is a really helpful infographic, I think, because looking at unpaid carers as a plus group, as the inclusion health group, we would then see that looking at the intersectionality of where they are in terms of the core 20, so the bottom quintile of deprivation across our ICS, but also where they are in terms of they are an inclusion health group in their own right. They have some support needs and specific needs as a result of being of providing unpaid care. We have some gaps in our data insofar as that the unpaid carers and currently going through pregnancy, those who may be suffering with severe mental health illness. But we do know, for example, that 7% of carers have chronic respiratory disease. And my next slide goes into quite a bit more detail around that, which is quite interesting. It just makes the case for some of the health conditions that unpaid carers are more likely to have. The caveat around this is, again, this is for our linked data set for only one of our places. So South and West Herts, we have, as an ICB, we have 3 places. We have South West Herts, East and North Herts, and West Essex, and the population slightly differs. So in South and West Herts, this was for a population of roughly 12,000 unpaid carers, and this was just highlighting that. So the numbers are there. So, for example, 37% of those who were identified as a carer were likely to have hypertension, 24% had anxiety, 31% depression. It just gave a big understanding of where we needed to kind of focus in on some of the needs that unpaid carers were presenting with. And then it moved into kind of looking at their presentation to what was the main condition they were presenting to kind of emergency and urgent care as well. So the main presented complaint, and then moving into the main, again, one of the main conditions and variants of kind of you were 43% more likely to present to A&E with a cardiovascular disease, or a cardiovascular issue, sorry, or 27% more likely to present with a respiratory infection or a complication related to hypertension, 6% with a stroke. Skin heart disease was quite high, and asthma and mental health was quite high as well. So they're just some of the reasons why people would present, but the variance in terms of a weighted carer population versus non-carer population identified this variance of 43% more likely, or 27% more likely to present based on unpaid care being the
Kevin, can I just come in for a second there? Because one of the reasons this is particularly important is that our ICP has chosen cardiovascular as an area if they want to prioritise this year. And so in terms of us thinking about how we get the carers agenda fully addressed at a very senior level, us being able to say, look, cardiovascular is a big ticket item, carers are doing worse in relation to this big ticket item than a lot of other people. You need to pay attention to this. So I think it's phenomenally important that that we mention that. The other point from the previous slide around, you may have seen that 42% of carers were on pain meds, and we've got major issues around overprescribing of pain, certain opioids in particular, We think it's very likely that carers are in the group that are being overprescribed to because nobody knows what else to do for them, so they're being prescribed some of those drugs. And then lastly, I'll shut up, sorry, Kevin, but the other thing is, you may have heard on Radio 4 today that the government is ceasing to fund the national helpline for people trying to get off antidepressants, saying that should be dealt with locally, which may well be true. But I think there is overprescribing of antidepressants to carers, and some of those carers will find it particularly difficult to come off antidepressants because their lives are very difficult. If we're not dealing with the wider determinants that make their lives difficult, then their ability to get off those antidepressants is going to be reduced. So lots of areas, again, where the voluntary sector, where social prescribing, where those interventions that aren't medical will have a significant impact on both our budgets and the health of carers. Sorry, Kevin, I'll shut up again now.
Yeah, thanks, Tim. Thanks for coming in there. And that goes into further on, I suppose, into non-elective admissions. That again just makes that case that Tim has alluded to in terms of the ICB's clinical priorities around circulatory and respiratory issues, is quite high there in terms of variance from general population. Just a little bit on young people's health and well-being and the demography of our young carers, because they're quite with the Core 20+5 framework for CYP, that's a piece of work that as an ICB we need to embark on in terms of mapping the inclusion health groups for them and mapping the Core 20. And young carers, I think, will be a specific inclusion health group we work with the system to identify through that mapping. And this is some of the early data we have found from various sources, including our Carers and Hearts and some of the voluntary organisations that are supporting our young people. So they're quite stark, and I'll pick out some information there just in relation to like 51% of carers reported having been bullied or picked on versus non-carers. So it's understanding, and I suppose the school census, that the report that's coming through, it's working with schools to support that identification of young carers and provide them the support. And I think that's an area that needs a little bit more work, that we need to support local authorities to support their schools, that they manage to kind of have the conversation with young people, but also provide the support and work with them in partnership about how we do that. Again, that's a little bit more in terms of dentistry, physical activity, and smoking. I won't touch on vaping because that's a whole other issue, but it's mentioned there. And then moving quickly into just education and kind of safety. And these slides are quite stark and interesting of themselves in terms of we do need to do more work with our data to understand the impact of providing unpaid care on our young people. And we know there's some national data on kind of those who provide care who have dependent children, but also what that looks like in terms of adverse childhood experiences and the wider issues that may come with that if you're providing 50 hours or more hours of care, but unable to kind of be fully present for the child. So it's understanding those kind of issues as well. Our next slides go into some of the work. So the previous data that linked to non-elective admissions was as a result of the linked data set we had with the Q Trust and Southwest Hearts. And I just wanted to showcase some of the work that East and North Hearts Trust are doing. And I've seen Jan Axel on the call just at the start, and they're doing some fantastic work around identifying carers and cared for people as a result of admission. And they have a fantastic kind of platform to be able to do this through their patient dashboard. And you'll see just here when they started some of the, I'll probably do it to service Dan, so apologies. They've got their nurse centre, and you can see the identified people who are cared for, the blue line, and the unpaid carer, and even flagging that at the start and understanding that those people are the unpaid carer has needs and support, and they've offered some incentive, some kind of rewards in terms of discounted parking, discount at the canteen, etc. And I think it's just a fantastic way of identifying that. Yes, you're an unpaid carer, and yes, your cared for person is currently unwell and is admitted, but actually you're providing some support to them still by presenting. So let's look after you and look after them at the same time. And I just found it was quite a nice example. And I think West Hearts are acute, and Southwest are doing some really good stuff as well there around that. And then we're just moving into the next slide. What's the importance of identification? And I suppose I'm preaching to the choir a little bit as to why it's important to identify them. But I think the next steps for us as an ICB is kind of the what now. So what we have this data, we know it's important to identify carers, but how do we support clinicians and non-clinicians in primary care space or in other spaces to continue to support those unpaid carers who may not recognise that they're an unpaid carer. And I suppose my next session today is working with the Personalised Care Collaborative and kind of their role that they may be in if they've got someone coming through, for example, who has the conditions that are more likely to present if you're an unpaid carer, for example, being on pain meds, for example, smoking, being an unhealthy weight, but they're not necessarily flagged as being a carer. Well, let's have the conversation in a different way and support them in that regard. So some of that Carers and Heart survey identified some. So we have some really fantastic links with our voluntary organisations, and Carers and Heart are a really fantastic partner to work with. And then some of our data, they've done lots of work in supporting identification of carers. This is our carers dashboard that our BI team produce, and it's we're working on a new iteration of this, but we've anonymized where we are in terms of practice names. But you can see we have some really fantastic practices and some practices that may need some extra support in terms of identifying some carers, and also just kind of doing that work with them is the next step to kind of identify that and trying to find the ways in. We know unpaid carers are more likely to are on the autumn booster vaccination cohort, so maybe that's another way to kind of provide some incentive practices to identify unpaid carers. So they're early conversations and early planning. Again, just some information on a survey from carers, so hearing their voice and expand that and what they feel. So in our area, 20% of carers said they'd missed health appointments. Again, just highlighting the need of being responsive and reactive to knowing that if a person's an unpaid carer, providing reasonable adjustments and being aware of that. So why is there a need for a proactive approach to this inclusion health group? I think it says it all there. In terms of, a third of carers said they had been close or had a breakdown. 45% said they weren't getting enough sleep. 33% of young carers, and that in and of itself is a stark statistic when you think of the impact they may have on their educational attainment and wider outcomes. I suppose the point I'm trying to make is that it's not just all about health outcomes. It's wider determinants to health, to health that we need to look at and focus on as to how we can bring a multi-agency approach to this as well, to support unpaid carers in the wider realm. Again, just some carers' health and well-being and just hearing from their voice. The next slide is quite interesting. It touches on a bit of the economic adversity of being an unpaid carer, and you'll see Healthwatch Hertfordshire recently did a cost of living report, and it's available on their website, and it makes for some really interesting reading. Apologies, the text on that slide is probably a little bit small, but again, the infographic just kind of says it all. Carers are almost twice as likely to not have enough money for the basic necessities, and at 90% compared to the 11% of the average. So it just really highlights some of the economic adversity affecting some people who are providing unpaid care. And that then links to some of the Health Foundation report into financial support. 4 in 10 carers under retirement age were not able to work as they couldn't do otherwise due to the caring role. It's kind of trapped, that sense of being trapped in the circumstance, and what we can do to support them and linking them with the right supports. And then I'd go through the next couple of slides insofar as that. So we have our, Tim, do you want to take over the social prescribing lens?
Yeah, so I think, as we said earlier, one of the key things in all of this is that what medics don't want to hear is there's a lot more work for them to do necessarily to support carers. But actually, we've got an increasing range of options to support carers, both through the voluntary sector and through social prescribing, which obviously is part of the role in primary care where people can spend time with someone, identify that they are a carer. That's why they keep coming to see the doctor with low-level aches and pains or borderline depression or whatever. So it's really important that we're analysing. And you remember I said at the beginning, I'm an anorak in two worlds, carers and social prescribing. It frustrates me deeply when the two don't interlink fully. And I think that's mainly been addressed now. But when social prescribing first came in, that some of that link between carer centres and social prescribers wasn't really made. But if you look at the top 10 client groups supported in our main social prescribing service in Hertfordshire, you'll see that the top 4 are all types of people who may well have carers, and the 5th one is carers themselves. And that 5% is something like 800 carers. So that's quite a lot of people who may well have been identified for the first time through the social prescriber. So that's a really important element of this. Next slide, please, glamorous assistant. And then, so these are the onward referrals, and there's a whole range of issues, but obviously you can see carers in Herts is there in the top 10. We might want them to be higher, but a lot depends on what the main presenting issues are for individuals. But again, a lot of these things may be benefiting the people that the carer is caring for as well. Next slide, please. And again, these are the outcomes that we're getting from something like 15,000, I think it is, interventions a year through social prescribing. This is all clients, not carer specific, but you can see a significant reduction in loneliness among clients. Next slide, please. But the third category here, we've got analysis which shows that those who came to the service for carer support, or where carer support was an issue and were lonely, significant difference made to their loneliness. And we know loneliness is a major issue in carers, and I think actually that's one of the bits of data that aren't on these slides so far. So that's another slide to think about, Kevin. Next slide, please. And this is the well-being scores for people on the social prescribing service. And as you can see, they're finding life more satisfying, more worthwhile. They're happier, and their feelings of anxiety have significantly reduced as a result of the social prescribing intervention. So this is all money in the bank in terms of taking pressure off primary care and improving the well-being of the population. Next slide, please. And this slide is a particularly significant one. If Jen Kenwood was here, I would remind her of the International Carers Conference in Sweden, where we discovered this wonderful picture on the left. So this was the amazing Professor Zaret from Penn State University. And what he did was take cortisol swabs 5 times a day from carers. The control group was carers who weren't getting a break that day. And the group that he was particularly interested in were the carers who were getting a break that day. Cortisol is the stress hormone. And basically, the black line is more like a normal cortisol line. So you wake up in the morning, and in the words of Professor Zaret, cortisol being nature's cup of coffee, you get a boost, and then it declines during the day. If you're a carer and stressed, you get up, and it's just another day, and you don't get the boost. Now, what we know is that if you are stressed continually without breaks for a long time, it's very bad for, guess what, your cardiovascular system and lots of other things like telomere length and stuff, which I don't really understand. But basically, it's bad for you to be stressed all the time. This piece of evidence on the left is one of the most powerful pieces I've ever seen, that a non-clinical intervention, in this case respite care, can have a significant impact on your clinical outcomes. I thought in 2015, when I saw this slide, the world was about to change and the NHS was going to show so much interest in the well-being of carers that everything and lambs would gamble in the fields. We haven't quite got there yet, but I think this is a really powerful piece of evidence. The right-hand side is 10 years of data from Carers in Hertfordshire Make a Difference for Carers project, which is basically a form of social prescribing for carers, but with a small amount of money available to help you get a tablet so you can work in your shed and get away from your husband or whatever it is. Those very specific, what will make a difference for you, Mrs. Blogg's interventions. And what that shows, again, non-clinical intervention leading to a 24% risk reduction in risk of depression. So that can even be costed in terms of the reduction in the cost of, yes, more lambs is a good idea. Reduction in the cost of antidepressants to the NHS, obviously better outcomes for carers who feel listened to and supported with what actually matters to them, which is what is making them feel depressed in the first place, rather than here's a sticking plaster. So this is all about the agenda. Why are we bothering to collect all this data? Well, because we can do a lot about a lot of these things if we're sensible and if we get up ahead. Next slide, please. So this is just, we're back to some depressing stuff here. So this is the Falling Short report from Nuffield Trust, which is basically saying local authorities are not keeping up with the needs of carers. Hardly surprising after 15 years of austerity and all the demography changing. But there's also been a shift, I think, towards expecting the voluntary sector to look after carers. And to some extent, I think if we get it right, a bit more of that stuff being done at the preventive end, helping people not to need to go to the local authority, especially if there isn't much on offer at this stage, and then help to go to the local authority when you need to, is part of what we should be working with the voluntary sector to support. And of course, the stuff we've been showing you around identification in primary care is all about the fact that every carer has a GP. They don't all ever see a social worker. So we don't want to wait until your needs are so desperate that you are talking directly to the local authority, even though not enough people are doing that. We want to help you in advance. Next slide, please. There are better people in the room to talk about some of this, actually, especially with Jan being here. But Kevin, do you want me to carry on? Do you want to pick up? Or...
Yeah, I mean, well, this is our last slide, so I'm happy to carry on. I think it's pretty self-explanatory in terms of doing more for discharge, and I suppose it links more in with maybe your task and finish group yesterday as well about what we're doing to kind of support discharge going forward.
Sorry, did you speak to me then, or Jan?
I spoke to you there. I don't know. I can't see anybody.
Sorry, I thought I'd been really horrible to put Jan on the spot. Yeah, so I mean, I think in terms of discharge, we knew pre-COVID that carers were often pressured to take people home without having a proper plan or understanding of what they needed to do. This evidence was clear back then in COVID. It's, I think, just as clear now. I think we've started talking yesterday at our task and finish group, and Jan, you couldn't be there, but unfortunately for you, you're going to have to meet with me and the other two trusts to talk about this. But we're talking about a kind of mechanism a bit like Martha's Rule, where you should be able to just put your hand up and say, this isn't safe until you understand what I'm going through as a carer to discharge this person at this time. So very early thinking, but we want to try and get a consistent approach across the ICB to make sure that we are responding to those carers' needs for that help to be in place. And lastly, and Jan and Jodie, you're both experts in this area, but I'm not sure we've got really good enough data at this point about where carer breakdown is the trigger that leads to the readmission. And I think that's an area where we really need to do a lot more work, because I think then, instead of carers being seen as a blocker, which I think they are culturally seen in some discharge situations, they'll be seen as the crucial, I hate to use the word resource, but the crucial aspect to getting it right, so the person isn't back in hospital in 2 weeks' time. So I think people get that in principle, but everyone's so pressured and so struggling. And I think, as with the work we've done with primary care, which has been successful, has been because we're trying to take a problem off them. So we've got to try and describe this in a way that says to discharge teams, yes, they may not get out today, but when they do get out, they'll stay out. And so please work with us. And certainly one of the carers we work with a lot, he's always saying, we want to be part of the team. We want to be part of the care team. Respect us and understand us and let us help you, because without us, it will all go wrong. I think that's the end. You've been very patient, and we did all the slides, which is amazing.
Yeah,
sorry,
it was
scary.
death by slideshow. Sorry. But if there's, I'll stop sharing, and I'm happy to take any questions if there is any, and hopefully I can answer them all.
Maybe I can help with a few questions. certainly in the chat, there's a lot of interest in the young people, young carers area, and the surveys that you've done. And there's obviously questions around terminology and whether young carers are hidden or overlooked, and work around that. And I think Ramsey Suleiman's put in about Carers Trust work and the challenge in there. I think the other thing that I would say about young carers is certainly the ministerial roundtable that was held about a month ago did focus on young carers, and certainly the HSC is putting more work into that, working with Department for Education. There's some specific work being connected together, which wasn't necessarily connected together previously on that, and hopefully that will be successful. So maybe people can ask questions around young carers quickly of Kevin and Tim, because I think what you put together has really encapsulated a lot around that area, which is a very emotive but a moving area, shall we say. So if anyone who's put anything into the chat wants to comment on that. Okay, I've kind of closed it down. That's not what I intended to do at all.
Well,
sorry.
Oh, Tammy.
Yes,
Hello.
go ahead, Tim.
Hello. Good morning, everyone. I'm sorry, I haven't got a question, but what a thought-provoking presentation. I've been writing notes throughout because there's definitely things that I can take away and bring into my acute hospitals with my Suffolk family carers and Carers First. So actually really helped me today, this presentation. So thank you very much. So I apologise, no questions, but really supported me in my role. So thank you.
Sorry, we have
Jan was trying to.
Jan Axel. Yeah, Jan.
Yes,
Please.
I just want to say thank you for Tim and Kevin for presenting our data. That was really nice to showcase the hard work we have within our acute hospital. With regards to young carers, my current work at the moment is I'm really trying to drive if we can have a similar trend for our young carers within the hospital, because as you can see, we managed to tap, because all of the cared fors that within that chart was all our adult patients. So we're still trying to explore in terms of what are the barriers with young carers, and just speaking from personal experience, and I know there is a lot of it's a bit more of a process. We can't just activate an alert, unfortunately, for a young carer, because we do require consent from parents as well. We had a few occasions where the young carer did speak up and say, no, I am a carer mum, even you don't feel that way, but I am, and I want that support. So luckily we managed to get to a reason, but it's how do we work through all of those situations, because a lot of families will they feel protective of their children, and they feel like having that label on them is a bit more challenging. But I don't know, where maybe I'm utilizing my personal and my lived experiences. I've been looking after my brother since I was 7, and I was in denial that I was a young carer, and I've only realized I was this past 2 years, or actually no, I've accepted this past 2 years, not realized I had an awareness. But it's just because how else can we utilize the lived experiences for them to increase its uptake? Because just knowing from our local community within East and North, we know that we have a high prevalence of young carers. But so at the moment, what I'm doing, I have a lot of training about language, about how we can approach parents a bit better and how we can word them. So the moment the questions that we use for our adult inpatient is, do you look after someone that will otherwise struggle without your support? Will this individual struggle without your support? So we're just trying to do that same approach with parents, because we don't want them to be have their backs up and on defense, because we're trying to help them. Because there's, like, for last year I attended the Young Carers Conference, and I've never felt so moved about all the wonderful things they do for children, and like, because they do grow up a lot faster and they don't know how to relate to other children, because they're a lot more mature in terms of they don't want to play. I want to learn how to garden. I want to learn how to cook, or I want to do all of these things, because I certainly felt that growing up. I never understood. I felt like I was the oldest one in the group. But you don't understand how to mitigate that. But But yeah, so there is a bit of a phenomenon with young carers and how we can reach them with the support of their parents, and hopefully they don't always have to go into that route where it requires a young carer to say, no, I need that help, I want that help, because it was a tough situation between parents and children. And that's all really, but thank you so much for summarising those words.
Thank you, Jan. Sarah.
Hiya, yeah, I'm Sarah from Luton Council. I'm a commissioning manager in Carers Lead. And this is more a challenge I think I face in Luton. So if anyone's got any wonderful pearls of wisdom, I'd be really grateful. But in Luton, it feels we are a little bit disconnected between adults and children. And I put together an all-age carer strategy, which I'm really pleased will soon be published. But my worry is that although we have a wonderful service for young carers and we have chums and they do an amazing job, it feels very disconnected. And what I'd love for it to be is this completely holistic approach to carers, not, well, children's are over there and adults are over here. And I worry that in that the young carers, despite the wonderful service, are still getting lost. And I don't know if anyone has any words of advice for how you successfully bring together that as one big holistic approach to carers and getting it right for all those different carer groups. So for example, obviously you've got parent carers and all kinds of other diagnosis specific carers in that, and I sometimes feel a bit overwhelmed about how much I need to do to meet the individual needs of all those carers. So
Paul, can I come in on that?
please.
Yeah, no, do.
So there isn't a magic bullet, I don't think, but I think there are some real opportunities coming down the road at the moment. So, and I think we're probably fairly typical in Herts and West Essex. So 3 years ago, we didn't have any young people social prescribers. We have about 15 now. And we also have some children, young people's health and wellbeing coaches. And what this means is there are other ways of picking up young carers than through the standard young carers stuff. And in fact, the 2 health and wellbeing coaches are based in Hitchin, spend most of their time in 2 schools. So there's partnerships like that, which I think are going to change the game. But obviously, it's really important that then that primary care get to see the sort of data that we're showing you about young carers, because those teenagers, whatever, are going to get into health problems that other people don't have. We know from the national survey they're in more joint pain and everything else, presumably because they're moving and handling inappropriately. We can get in there and do something about that if we identify them. So I think it's those kind of partnerships that are crucial. And I think the new integrated neighbourhood teams, what Kevin and I are planning to do is to go to them with what we know about their carers. And unfortunately, young carers will always be microscopic in terms of their numbers in primary care. But the scary thing is what people are pointing out in the chat, that schools don't seem to notice that. I mean, when we started in the 90s, schools all said, oh, no, we don't have any of them. Just as primary care used to say, oh, we don't have any carers on our list. So there's this huge culture change, and the evidence is critical there. But I think any way that you can link up work going on in schools, counselling, school nurses, with the children and young people social prescribers, or generic social prescribers if you don't have specific ones, and get that local focus in a community with the support of the ICS and the local authority, building that partnership with the voluntary sector has got to be the way forward. And I think the reason that Kevin and I spent so long on this data, it's coming out of our ears, is that no one can turn around and say, oh yeah, well that's not much of an issue anymore. I think it's clearly a very, very significant issue. It hasn't been noticed properly for years, but we're going to have to focus on it if we're going to do what the ICS is supposed to do.
Thank you, Tim. Thank you, Tim. I think that, unless you want to respond straight away, Sarah, I'm not sure.
No, I'd like Tim to come to Luton. Can you do that? Yeah, thanks.
Many Tims across Hertfordshire. Ramsey Suleiman, you're.
Hello, yeah, just to come in on the young carers point. So I'm Ramsey. I work for a charity called Carers Trust, a charity for unpaid carers. And yeah, I think I just wanted to pick up on a few points. as well. So Jan's point around young carers self-identifying is a really important one. I think that's one of the reasons why hospitals do struggle, often because maybe the young carer isn't there. They're at school whilst the person they care for is in hospital, and actually it's not right in front of the professional. And then the question is asked, do you have anyone at home looking after you? And adults tend to maybe point to their partner or the other adult in the household, or whoever it might be, and sort of forget or not appreciate the extent that their child might be caring for them. So that is a sort of a massive issue. Carers Trust are working with ADAS on renewing the No Wrongs Door MOU, which is sort of encouraging adult social care and children's social care to certainly work together. But as part of that, we do want the NHS to also be brought in. So actually, it's easier for everyone to identify young carers, and then that information be shared across the system. And then schools is a whole other thing as well. And again, Carers Trust are working to try and improve that. But I think there's something around working with the person with care and support needs who might be reluctant to identify their child as a young carer, to sort of remove that stigma, because actually it isn't. People might go to, oh God, social services are going to be involved and all that sort of thing, whilst actually it's about supporting the whole family and ensuring that the person with care and support needs gets the help that they need to ease some of the caring that the young carer has to do. So it's actually about that whole family approach I'm sure you're familiar with, to make sure that each member of that family has the support that they need to ensure that the family can live the lives that they all want to live. But thank you again for the really good presentation. Like everyone said, it was really informative and really insightful. So thank you.
Thank you, Ramsey. Anne, I think this will have to be reasonably quick because we're running out of time. So
yeah,
Anne,
really quickly.
Then Andrew,
yeah.
Thank you.
Hi, I'm Anne Betts-Walker from Cambridgeshire. Just to sort of pick up on something that Sarah had said, we're going through now our second iteration in terms of recommissioning for our all-age carers service. And from a commissioning point of view, what we did with our original sort of strategy, which has now been renewed, was we commissioned it as one service, so children's, adults and mental health. It's a bit like herding cats, getting the three sort of commissioning types together, but that was the starting point, and now we can be a bit more specific about it. So we're looking at that transition period from young adults, sort of young carers into adult carers, and making that a sort of a very specific piece of support that we're putting into the service that we're recommissioning. But if you want to chat about it offline at another point, that'd be great, if that'll help.
Okay. So really,
very quickly, Paul.
Yeah, no, very quickly, and then
very
I'll
quickly,
give you thanks.
Yeah, just in my experience, the best way forward for young carers is their own voices, and actually empowering, facilitating young carers to be advocates themselves for change. They are the best advocates and the way forward, as are ex-young carers who then become carers, and that have the time. Basically, that's the key issue within, and affecting a cultural shift. I remember the heady days of Every Child Matters and UN Article 12, the voice of the child. Well, there was political will then in those days. There needs to be political will again.
Okay, thank you. As we have all said, there's a huge amount of content here, and we haven't even got to the economic questions, which are tricky ones as well. So I would recommend everyone, when they get the slides, to go through them in detail. End of the day, as both Tim and Kevin have said, data does give you some element of power if used in the right way, and that isn't always easy to get the right people together, and this obviously shows that you can, and there's a willingness to do that. So thank you very much, Kevin and Tim. You've really opened the eyes of many here, I think, to areas that they may not have considered, and certainly looked at the data in ways that perhaps hasn't been possible everywhere, but it shows that it is possible and it can be done, which is absolutely great. We are just about up to the line. If there's any burning things coming from ICSs that you want to share between yourselves, can you either put them in the chat, or if anyone wants to chip in straight away, then you have a couple of minutes to do so. Otherwise, I will close this meeting with great thanks to everyone who's contributed to this, and especially our speakers. So if anyone wants to put things in the chat, or to follow up, I think many of the addresses and many of the email contacts are there for you. But an absolutely important subject, and showing the new way of working by locally talking about neighbourhood teams, making this a multi-agency activity is really the way it is going. But there needs to be policy push at the top, both in DHSC and in NHS England, and certainly when they come together, it works better for everyone. And you can see that in some cases here. And it was great to talk about social prescribing link workers again in this context, which I think is always really very important as well. So thank you, everybody. Next meeting is when, Steve? I'm sorry, I should have thanked you as well.
The next meeting, we've got the 14th of December at the minute. That's the date that we've got down. But if anything is to change, I will let the group know as soon as possible.
And sorry, the only other thing that there is a lunch and learn on the 20th of September, which is also about data, with the Health Foundation Network Data Lab. So if anyone is interested in a further exploration of data, that is available to people. If you look in the chat, there will be a link to that, and you can get signed up for that. So we are just up to the line. Thank you, everybody, and have a good day.